Hi, everyone. Welcome to Osteobites. Thanks so much for joining us today. My name is Christina Iptoma, and I am mom to Osteo Angel Dillon and Director of Scientific Programs at MIB Agents. And today on Osteobites, we are joined by Dr. Kelly Faulk, a pediatric oncologist at Children's Hospital, Colorado. And she will be reviewing the open phase 1/1b clinical trial evaluating the combination of Losartan and Sunitinib in the treatment of pediatric and adult patients with relapsed or refractory osteosarcoma. Thanks so much, Dr. Faulk, for joining us on Osteobites today. Everyone, please feel free to submit questions during the presentation through the Q&A in Zoom, and we will share those with Dr. Faulk during and after her presentation. A little bit about our guest today. Dr. Kelly Faulk is a pediatric oncologist at Children's Hospital, Colorado Center for Cancer and Blood Disorders, where her clinical and research focus is the development of early phase clinical trials to investigate promising new agents for high-risk pediatric cancers. She's on the experimental therapeutics program team and serves as the leader of the high-risk leukemia lymphoma program. She has developed and leads several early phase clinical trials and serves as the site principal investigator for numerous others. She completed her medical training at the University of Colorado School of Medicine, did her pediatric residency and pediatric hematology oncology bone marrow transplant fellowship at Children's Hospital, Colorado, and also completed an additional fellowship in experimental therapeutics at Children's Hospital, Colorado. And she met her wonderful husband, Wade, in medical school, and they have 3 great kids that keep them busy. Just a few announcements before we get started. We're super excited to have you here with us, Dr. Faulk. This September is Childhood Cancer Awareness Month, and so we hope you join us by signing up as a BOW agent volunteer. As a BOW agent, you'll help raise awareness by distributing beautiful gold bows throughout your community on mailboxes, storefronts, schools, and more. And each gold bow is a powerful symbol of hope, resilience, and solidarity for children and families facing cancer. Help us turn neighborhoods gold and make a meaningful impact one bow at a time. I'll add a link to the form to get more info in the chat. Also, I just wanted to note we are still riding the high of our Factor 2025 Osteosarcoma Conference. That was a couple of weeks ago in Salt Lake City. We're going to be publishing the conference proceedings shortly with all the abstracts. And thanks to the generous support of the Chung family because of Isaac, we have recordings of all the general session on our YouTube channel. So I'll put a link into the chat where you can access those. And we did announce our 2026 location and date at the end of our conference this year. So we will be in Columbus, Ohio, June 25th to 27th next year. So save the date for that. We hope to see you there. And with that, I think we can go ahead and get started with Dr. Faulk's presentation.
Awesome. Thank you so much, Christina, and for the opportunity to join and be here and share this work with everyone. Okay. I'm just going to use this screen to get us started. Let me make sure you're seeing it right.
That looks
Is that
great.
Okay.
Yeah, perfect.
Great. Well, as Christina said, what I would like to share today are really a lot of the kind of biologic principles and rationale for the development of this phase 1/1b trial that we developed here at Children's Colorado, but was very much a collaborative effort and actually stemmed initially from some comparative oncology research that came from the Colorado State University, CSU's Flint Animal Cancer Center, which is a world-renowned animal cancer center, and which actually treats a lot of canine osteosarcoma. So certainly my title plays on that a little bit with old drugs, new tricks, that we definitely leaned heavily on our veterinary colleagues, and comparative oncology is such a great opportunity for us to learn about new agents for our patients. And we'll kind of go into a little bit about why that is. But the second thing to just mention is this is a trial that is repurposing drugs that are already FDA approved for other things. And certainly that allowed us a much shorter timeline in starting the trial and getting it open and enrolling than often is the case with new, more experimental drugs. So for that reason, we were really excited to work with the Animal Cancer Center at CSU and kind of get this going for our patients. So This is the trial that ultimately I'll be talking about after we go through a lot of the background. So again, it's a combination of the already kind of commercially available drugs, Losartan and Sunitinib, for patients across the age range, so both pediatric and adult patients with relapsed or refractory osteosarcoma. And I included the clinicaltrials.gov NCT number if that's helpful for anybody to search it. So I certainly, sorry, let me just move something so I can see a little bit better. I certainly don't think I need to describe to this group really the ongoing, is it going, poor outcomes, there we go, that our patients with relapsed osteosarcoma have. For the 30 to 40% of patients who relapse, the 4-month progression-free survival is just 12%, meaning following relapse, this disease typically progresses really quickly. And thus far, we've really been unable to identify therapies that can prolong survival aside from surgically removing areas of disease, when it's feasible. And so this graph you may have seen before, but it depicts the progression-free survival of nearly 100 patients with relapsed osteosarcoma who were enrolled onto various children's oncology group trials. Again, really showing how quickly progression occurs for the vast majority of patients. And even for those who don't show progression, really 0 patients in this cohort were able to achieve an objective response to their therapy, meaning like tumor shrinkage. So even just the achievement of getting disease stability would honestly feel like a win for many of these patients and their families. Of course, the lack of effective treatments has really not been for lack of trying. We've thus far just been unsuccessful for various reasons, including a lot of disease heterogeneity. Really, there's no one-size-fits-all approach, as is the case with many cancers, and then also an absence of really commonly occurring druggable mutations that we could target with a specific medicine. So specifically, the concept of using the immune system to help fight osteosarcoma is something that has been considered for many years, really over 100 years. If you look back to the work of the bone sarcoma surgeon, Dr. Coley, in the late 1800s, where he found that patients who had a postoperative infection actually had improved survival, presumably because of the activation of the immune system against the tumor itself. Overall, this hypothesis that immunotherapy is potentially a really valid strategy for osteosarcoma is really based on a lot of factors. And the first being, although osteosarcoma lacks these recurring druggable mutations, it does in general show a really high level of genomic instability and complexity, which at least in many adult tumors has been associated with improved response to immunotherapies, because the tumors are just constantly producing this really large panel of neoepitopes, or things that appear foreign, which therefore really drives this anti-tumor immune response. Second, we know that normal bone cells cooperate with the immune system for bone development and maintenance, so presumably would have interplay in the development and maintenance of bone tumors as well. Third, beyond Dr. Coley's observations, research has shown that when compared to other sarcomas, osteosarcoma tumors really demonstrate a higher anti-tumor response. Namely, they have a higher percentage of so-called TILs, or tumor-infiltrating lymphocytes, and that patients that have a bigger response or have more infiltration of the tumor with these T cells show prolonged survival. And then finally, our veterinary colleagues have shown that for dogs with osteosarcoma, the recruitment of different immune cells, ones that are immunosuppressive, like inflammatory monocytes or regulatory T cells, are really what seem to be essential or needed for the tumor to develop new sites or metastases, and that having more of these cells correlates to worse outcomes. And so this may be just a good moment to expand a little bit on this whole idea of comparative oncology, where we work with vets. And certainly for osteosarcoma with dogs in particular, this is really a huge opportunity for us to learn and develop new therapies for our patients, because canine osteosarcoma is essentially biologically and clinically identical to what we see in humans. And the fact that it's naturally occurring, unfortunately, for these dogs, but also in a host that has a similarly complex immune system that we do, really provides a great opportunity to study specifically immunotherapies in this way. Additionally, dogs, really mostly the larger breed dogs, unfortunately have a pretty high incidence of osteosarcoma. And so clinical trials for dogs tend to accrue pretty quickly and can get answers much faster than most of our clinical trials accrue, because in general, it's a rare disease in humans overall. So unfortunately, despite the evidence that immunotherapy may be a useful strategy, attempts at this thus far have not panned out, though I certainly don't think as a field we're ready to stop working in this arena. It's just more likely to be a more complex answer than we would all hope. Again, not just a one drug that will likely do this, and unlikely it will not be a one-size-fits-all type approach. So next I'll be getting into the biologic rationale for the combination, the Losartan and the Sunitinib, and I'll go into the Canine trial that was performed for that. So starting first with Losartan, this drug's mechanism is as an angiotensin 2 receptor blocker, otherwise termed as an ARB for short. And its largest use is really for high blood pressure, but it's also used to treat kidney disease associated with diabetes as well. The interest really started to grow in studying Losartan as a cancer therapy when several retrospective studies showed that drugs in this class, Losartan and others, that inhibit this same pathway seem to be, first, protective against the development of cancer in people who did not have cancer, and second, be associated with longer progression-free survival and overall survival in patients with cancer. From a mechanism standpoint, we know that dysregulation of this whole renin-angiotensin pathway, that you see on the right, that helps control blood pressure, also really affects all of the main hallmarks of cancer, like angiogenesis or blood vessel growth and tissue invasion, migration of cells, development of metastasis, and really evasion of cell killing or apoptosis. And so it has made some sense that inhibiting this pathway would in some way inhibit cancer too, as a general hypothesis. Further, though, data arising since then has also now shown that Losartan likely stimulates and enhances the anti-tumor response to cancer. So it also has an immunomodulation mechanism. And really, I wanted to break that down into three main actions, and then I'll go into a little bit more on each of them. So first, we know that inhibition of the renin-angiotensin system can inhibit the recruitment of those immunosuppressive immune cells that we talked about. And this has really been a main focus in the canine osteosarcoma research so far. Second, we believe that it can help normalize the tumor microenvironment, which is basically, the local environment or ecosystem that surrounds the tumor, and has usually been pushed by the tumor to really help the tumor thrive as opposed to die. And third, it has shown to stimulate directly an anti-tumor response. So not only does it suppress the pro-tumor response, but it directly stimulates an anti-tumor response. So we'll go through those a little bit now, first with the inhibition of recruitment of those immunosuppressive cells. And so we know that under normal conditions, chemokine pathways can recruit bone marrow cells to sites of inflammation. But these pathways are also used in cancer to bring inflammatory monocytes, which are termed IMs in a lot of the presentation, to the tumor site or where the tumor is trying to make a new site to metastasize. And once there, they can differentiate into immunosuppressive macrophages, which are called TAMs. The recruitment of these monocytes is really largely mediated by this CCL2, CCR2 axis, where you can see that a chemokine, CCL2, travels to and binds to the CCR2 receptor, which is on the monocyte, and then it directs it to the tumor site. We also know after it gets there that this axis really helps drive that monocyte toward becoming a really specific type of macrophage or TAM that is more pro-tumor, and that's the M2 phenotype that you see on the bottom. which really helps the tumor in various ways to unfortunately thrive and metastasize. So in lab work by our veterinary colleagues at CSU, they showed that for mouse models with cancer, shown here, these were colorectal cancer models, but they also did it in a metastatic breast cancer model. Treatment with Losartan reduced the number of inflammatory monocytes and those TAMs within the tumors. And further, they showed that mice treated with Losartan showed a reduction in their metastatic tumor in the lungs when compared to controls. So this is just the bioluminescent imaging showing the lung tumors in the control versus the Losartan treated mice. Again, this was the colorectal cancer model. By delving into this further, they were able to identify that one of the main mechanisms that they think Losartan does this is by inhibiting that CCR2 receptor. So it prevents that normal recruitment process of the inflammatory monocytes to the tumor site. So this is an assay that they developed, which simply used human monocytes and then watched how well they migrated across a plate in the lab to the CCL2 chemokine. And what they saw was a dose-dependent inhibition of this CCL2 mediated migration. Really kind of helping confirm that this could be kind of an underlying mechanism for how Losartan is doing this. And you'll hear more about this assay later because it's used on the Canine trial as well as on our trial as well. So next up, to talk a little bit more about how Losartan may normalize the typically very hostile tumor microenvironment. So this idea of normalizing the tumor microenvironment away from supporting the tumor is driven by really this idea that tumor vasculature has long been known to be really abnormal. So it's more of this like overgrown and really disorganized mess. And so it's pushed by really pro-angiogenic factors like VEGF, which is something else we'll talk about, but it really leads to this quote unquote hostile environment that's really characterized by hypoxia, a lot of congestion, and immunosuppression. So it's not allowing the immune system to fight back. Additionally, solid tumors, but sarcomas and osteosarcoma in particular, given their really mesenchymal origin, soft tissue and bone origin, they build up this really dense stroma that has a lot of collagen that really also makes it more challenging for things like chemotherapy and drugs to even get delivered into the tumor as well. And so, normalization of the tumor microenvironment can help alleviate that hypoxia and the congestion and really that immunosuppressive nature and start to drive towards a more anti-tumor response, as well as reducing that stroma and allowing for better delivery of our therapies. So this is a very broad approach in general to lots of tumors, but we'll talk a little bit more about Losartan specifically, because interestingly, there was a recent study in patients with pancreatic cancer. And particularly, these are patients with advanced disease that were identified to be unresectable at the time of diagnosis. And what this trial did was it was a phase 2 trial where everybody got Losartan added to the typical chemotherapy regimen, really with the goal of trying to improve the ability of these patients to get a margin negative resection. So ability to resect the tumor but have no viable tumor, or margin negative, really seen on the outside portions of where the resected tumor is, for these patients who otherwise would not have been able to. And so what they found was that amazingly over 60% of patients were able to achieve that margin negative resection compared to what would have been anticipated with chemo alone, which is about 10%. So this was a pretty amazing finding, which was a lot more significant than anyone anticipated. And to give you a sense, the study had when we make studies, we have to kind of set what our anticipated findings are going to be, even though, of course, that's why we're doing the study. We don't know. And they enrolled enough patients to at least be able to identify a difference from 10% to 25%. So that was the kind of improvement they were hoping for. And they got, over 60% of patients able to get to this full resection. So the graph on the right is really represents an individual bar for each patient. So this was a cohort of about 50 patients. And so bars going down really demonstrate tumor reduction. in terms of tumor size while on treatment. And so the bigger the bar is, really the more reduction that was seen. And so really shows you in a picture how dramatic many of the responses were in a patient population in which this would not have typically been expected. And so the hypothesis is that adding Losartan really, for one approach, may help normalize this tumor microenvironment and allow better delivery of the chemo that was given with it, allowing it to work better and then subsequently achieve the resection. And our adult colleagues are really continuing to utilize Losartan combinations in pancreatic cancer. And there's an active trial, last I checked, that's adding Losartan now to the immunotherapy nivolumab. So I'll be interested to see when any results from that are available. So finally, we'll talk a little bit next about how we believe Losartan may also stimulate the anti-tumor response. And so this actually goes back to the pancreatic cancer study, where they were able to take samples from the patients that were enrolled. And in addition to likely helping with better delivery of chemotherapy to the tumor, researchers looked at gene expression changes and also the numbers of immune cells within the tumors, and found that patients treated with Losartan and chemo had really an improved kind of endogenous anti-tumor response. They had higher IL-12 and TNF-alpha expression and higher levels of those TILs, the anti-tumor T cells, with reductions in the more immunosuppressive things like regulatory T cells and TAMs. Additionally, there's another older study that showed that inhibiting that renin-angiotensin pathway, this time with a different blood pressure medicine called lisinopril, but really a similar approach of inhibiting that pathway. They did RNA sequencing and gene set enrichment analysis on, this is again, pancreatic cancer. And so they looked at tumors that had been resected and compared patients that had been treated with lisinopril versus those that were not, and found that those treated with lisinopril had upregulation in pathways involved in T cell activation and antigen presentation to the T cells compared to patients not treated with the lisinopril. So to kind of summarize again, the different mechanisms that we think Losartan may have as an immunotherapy, really to enhance anti-tumor activity. And next up, just a few slides now about the Sunitinib portion. And we often call Sunitinib Sutent. It's a little bit of an easier name to say. And so Sutent is a tyrosine kinase inhibitor, or a TKI, that inhibits several cell surface receptors that are depicted here, like VEGF, which ultimately then kind of inhibits all these downstream pathways that we know are driven within cancer. And so it is FDA approved in several adult cancers and has been studied in kids in both phase 1 and phase 2 trials. So the benefit being we have proven safety and dosing available for the pediatric side, which was, of course, important. In terms of rationale for its use in osteosarcoma specifically, we know that VEGF appears to be an important factor because retrospective studies have shown that higher levels of VEGF have been correlated with disease progression and reduced survival in patients. So inhibition of VEGF could potentially, mitigate that as a theory. Sutent has also shown direct activity in osteosarcoma cell lines and mouse models, and there are some published case reports of patients specifically with osteosarcoma that have been treated with it. And then finally, and what we were most interested in from an immunomodulation standpoint is that there has been a suggestion that Sutent actually can reduce those immunosuppressive cells like the regulatory T cells and myeloid-derived suppressor cells, or MDSCs, within the tumor. So it may also have a more direct immunosuppressive role in addition to its tyrosine kinase kind of inhibition of all those important cancer pathways. So as for the combination, this kind of gets back to the work done by our veterinary colleagues at CSU. because Sutent actually has a dog equivalent drug that they used in osteosarcoma for dogs. They evaluated Losartan and Sutent together in an osteosarcoma mouse model and were able to show synergy, which you can see here where they showed better tumor control with the combination compared with either drug alone, and certainly compared with control with no treatment. So they really used that data to help them develop a clinical trial for dogs with metastatic osteosarcoma. And so what they gave is Tosarinib, which is the dog equivalent of Sutent. And they tested typical dosing of that with escalating doses of Losartan in cohorts of dogs. And so they started with Losartan at 1 milligrams per kilogram given twice daily, and then they increased it to 10 milligrams per kilogram given twice daily. And overall, importantly, they found the combination to be really well tolerated with minimal side effects. And of course, one benefit of this combination is that both of the drugs are oral. And so it's easy to administer, as you can imagine. IV chemotherapy given to dogs is even more challenging than it can be in people. And so the ability to give these both orally, I think, was helpful to owners and families. And importantly, at the higher dose of Losartan, they saw several things. The concentrations of Losartan, once they were at the higher dose, were consistently above a target level that they had identified in that earlier preclinical work in the mouse models, and really met these levels that they felt should, based on their work, effectively inhibit the monocyte migration. Second, they saw a clear reduction in the monocyte migration by that assay that I had described before when they tested it in the dog's blood. And they also saw a compensatory increase in the plasma CCL2 levels. That's that chemokine. And so here you can see some of that data, where on the left is a graph of the chemotactic index, or that's the monocyte migration assay, where they showed the treated dog's blood and showed reducing migration noted over the course of a month of therapy, as well as this compensatory increase on the right in the plasma CCL2 levels with therapy. So most impressive, and this is definitely where we got involved and they were excited to share this data with us, was the response that they saw. And so again, on the trial, they tested 2 cohorts, both with Tosarinib, but one at a lower dose Losartan and then one at the higher. And they also compared that to a historic control cohort of 24 dogs that they had treated with Tosarinib alone previously. And so you can see at the lower dose Losartan combo, there were 3 dogs, or about a third of the patients in that cohort, who achieved stable disease of 8 weeks or more. And so that's already pretty improved from what we'd expect from Tosarinib alone. And then at the higher Losartan combo, not only did a fourth of those patients achieve prolonged stable disease, but a fourth actually had a partial response, which is nearly unheard of with osteosarcoma tumors, because of how dense the stroma is and the bone involved. To actually see tumor shrinkage was pretty remarkable. So the median progression-free survival of the higher Losartan dose combo was over 100 days. And just to give some context, because I certainly needed context when dealing with dog osteosarcoma that I don't treat, but if there was a dog with metastatic osteosarcoma that received no therapy, the typical PFS is probably like 30 days or less. So this was a significant improvement from usual, and it was with a regimen that was super well tolerated, could be given orally, and was pretty easy to administer to the dogs. So these are some of the chest x-rays of the responders on the trial, many of which achieved reduction in their tumors within just 8 weeks on therapy and were able to sustain that improvement and stability for many more weeks after that. So when our veterinary colleagues shared their results with us, we were obviously very excited and really quickly worked with them to develop a clinical trial to test the combination in our patients, again, with the benefit of being able to get it open, I think, much sooner than usual, given these were both commercially available drugs that we already knew dosing and knew kind of a safety profile for kids and young adults. So we can move into going into some of the basics of the trial, and then certainly there will be time at the end for questions for sure. So the study design on our end really has two parts. It's a phase 1b study, and pretty classic design in that the first part of the study starts with the dose escalation part, where we are looking at different dose levels of the combination, similarly to what they did in the dogs, to really try to identify side effects, how well tolerated it is, and try to find the best dose of the combination before then proceeding to a second part, which is an expansion cohort of additional patients that would then be treated at the dose that's identified in part A. And so here I listed the sites for the trial. We are the lead site and developed the trial, but then our colleagues at the University of Colorado also opened it. That's the only adult site participating. And we have pediatric colleagues at both Children's of Atlanta and then most recently at CHLA. So here are the dose levels for the first part of the trial. So we started on dose level 1, but we did, of course, also build in a dose level -1 that would be available if there was excessive toxicity seen, which thankfully there has not been. But then you can see that for dose levels 2 and 3, we increased the Losartan dose, really mirroring what was done in the dog trial, given that they had identified really it was pushing that Losartan dose that really seemed to correlate with the increased tumor responses. So that was our first goal, was try to increase the Losartan dose and ensure that it's safe and tolerable. And then for dose level 4, we stay the same on the Losartan dosing, but we increase the Sutent dose. So I will provide kind of study updates about where we are at the end more fully, but just to say now, we are currently enrolling on dose level 3 because both dose levels 1 and 2 have really proven to be very well tolerated with minimal side effects to tell us that we should not continue to try to increase that dose. And so that is where we are currently at. To review a little bit, and we don't have to go into all of these in huge detail, but these are really the objectives of the study. And so as a phase 1b study, obviously the primary objective is to really identify the safety and tolerability of this combination. So the goal at the end of this trial is to really say, is this a tolerable combination? And if so, what are the best doses of these two drugs that we should use together? And the way that we'll do this is, of course, to look for pre-specified dose-limiting toxicities or toxicities that we have said would tell us that we should not kind of continue with the current dose or continuing to expand. Secondarily, there's a lot of other things, of course, that we want to look at. First being the concentrations or the pharmacokinetics of the Losartan when it's given with Sunitinib in our patients. And so there's a lot of specific things that we can look at in the blood to see really the metabolism and concentration of Losartan in the blood of our patients, and then compare it to that of the dogs who had responses. We also want to understand more about the pharmacodynamics of the combination. And so really the effects on the tumor, like what are the biologic effects of this combination, really speaking entirely to what I just showed and all of the background. How does this affect monocyte migration with that assay? How does it affect the plasma CCL2 levels? And how does it affect like the peripheral monocyte population? And so these are all of the kind of biologic studies that are being done so that hopefully by the end, we're able to not only understand safety and efficacy, but understand the why. Why is it working or why is it not working potentially? And finally, of course, we want to understand what the preliminary anti-tumor activity is of this combination. A phase 1 study is going to be smaller in terms of enrollment in general until we can prove that this is a safe combination and understand the best dose. but we do hope to see responses. And so what we're going to be looking for, given osteosarcoma so rarely has actual objective responses, what we've really moved to largely is looking at disease control rate. So how, ability to achieve even stable disease, but certainly partial response or complete response. But then also looking at that 4-month progression-free survival, so that we could compare it to our historic control, which we spoke of in the beginning is just about 12%, currently based on available data. There is a ton of exploratory things being done as well, really largely looking at the immune system. And so changes to the T cell populations while on treatment, changes to cytokines and chemokines while on treatment. And then we'll get to this, but there is the ability for patients who are able to achieve either disease stability or a response for a certain number of cycles. If they have lung metastases that are amenable for resection, we allow patients to have the resection on the study and remain on treatment. And so for those patients, if they were to happen, then we have a lot of studies kind of already developed and planned that we would be able to look at the tumor itself and see how infiltrated it is by specific T cells, and also how the gene expression looks within the tumor itself. So just to talk a little bit about the treatment plan, it is a little bit different than in the dogs, mostly on the sunitinib side, because the way that we dose sunitinib and what was shown in that pediatric phase 1, where they identified the way to dose sunitinib in kids, is on a 4-week on, 2-week off schedule. So it's like a 4-2 schedule is what we call it. So the Sutent is given once a day for 4 weeks, but then there's a built-in 2 weeks off break, whereas the Losartan is given every day kind of continuously through the cycle. So it ends up being a 6-week cycle to allow for that 2-week Sutent break. And then scans or response assessment are done after the first cycle, and then subsequently every 12 weeks after that, or every other cycle after that. This is really just the basic eligibility to give you a sense of the patients who would be eligible, but certainly feel free to reach out to me if there's more specific questions or any of the sites that are participating. But because of what we know in terms of dosing for Losartan and Sutent, we opted to have a lower age limit of 10. And certainly we're not wanting to exclude patients that are younger, but in looking back at the Children's Oncology Group cohort, it's a very rare patient that is under 10 years of age at the time of osteosarcoma relapse. And so we didn't feel like we were overly limiting, eligibility for patients, we hope. And certainly helped us feel good about the safety of the doses we were using, that it was a slightly older as opposed to, toddler age, for instance, patients. So certainly this is for patients with relapsed or progressive osteosarcoma. And in the first part where we're looking for the best dosing, the dose escalation, it does require that patients have measurable amounts of disease. And so a tumor has to either be a centimeter or more, or a lymph node that is 1.5 centimeters or more. But then once we get to the cohort expansion, once we know the best dosing, that will allow patients without a requirement of disease size. And so you could even enroll with completely resected disease. So a lung nodule that's been completely removed could then enroll once we get to that part. There are some organ function requirements, like for blood counts and kidney and liver and heart function, that patients have to meet. Certainly you have to be able to take oral medications. We want patients to have a normal blood pressure for their gender and age, certainly because one of the biggest concerns with increasing a blood pressure med is that the blood pressure could go too low, although we have not seen that. We did exclude patients who've had a history of cardiac irradiation. This is pretty rare for our patients with osteosarcoma to have, first of all, used radiation up to that point. because osteosarcoma tends to be less radiosensitive, but certainly to the area that would impact the heart would be even more rare. But we do know on the Sunitinib phase 1 study that they did see a reduction in heart function for patients who had had a lot of anthracyclines or specific class of chemotherapy that we know can affect heart function. And recognizing that the majority of our patients at the time of relapse have seen a significant amount of those anthracyclines, we wanted to build in other protective factors to try to reduce the risk of any impact to heart function. There's some other things related to Sunitinib and some risks of bleeding, so no bleeding disorders or recent blood clots, symptomatic heart disease, and importantly, patients who've used a prior TKI, because as you likely know, it's a large class of different medications, is permitted. So that does not exclude you from participating in the trial. So really, I'm nearing the end, I think, really just to kind of summarize where we are for the trial. And, we initially opened to accrual at 3 sites initially in 2019 and 2020. And were able to enroll to that first dose level, and then opened up dose level 2 in 2021. And then most recently, we were able to move on to dose level 3 just this year. Unfortunately, at dose levels 1 and 2, we have not yet seen tumor responses. And so we wanted to take a preliminary look at the pharmacokinetic data or those drug concentrations from those dose levels really before we proceeded to dose level 3. And what we found is that the patient's Losartan concentrations were lower than what were expected, at least based on comparing the doses we were using and what were used in the dogs. And certainly the concentrations were lower than what was seen in the dogs who achieved responses. And so Losartan is actually typically dosed just once a day in humans. So that had been our initial dosing plan for dose levels 1 and 2. However, given the preliminary pharmacokinetic findings, together with the fact that patients really were not experiencing any concerning side effects in the early dose levels, it's been very well tolerated. We opted to amend the protocol to increase the Losartan dose further for dose level 3 than what we'd originally written, but split the dose by giving it twice daily, which is actually also how dogs are given Losartan. And so we're hoping that it more closely mirrors the dosing for the dogs. And again, we're trying to push that dose in a safe way, but as far as we can, because patients have thus far tolerated it so well, to really see if we can get those responses that the dogs got. So far we have enrolled just 1 patient at dose level 3, and we don't have any really preliminary PK data back or anything yet. So it's really too early to say anything definitively about these modifications since it just reopened. But we will plan to continue enrolling to dose level 3, and then we would do another kind of interim analysis before we decide about proceeding to that dose level 4, which, if you remember, doesn't increase the Losartan further, but would increase the Sutent dose slightly. Just to add, as I mentioned, CHLA is really our newest site. And so they're still in the process of opening, but we anticipate hopefully by the end of the summer that they will be open as well. So then we'll have a site on the West Coast as well, and hopefully have more access for people interested in the trial. So just really briefly, obviously, you can see this was a huge collaborative effort, and we've had a lot of collaborators. First and foremost, with our veterinary colleagues at CSU, Dan Regan and Stephen Dow are the 2 main people who performed a lot of this research that led us to developing our trial. And then all of our clinical colleagues at University of Colorado, Atlanta, and CHLA, and their huge groups of teams that have worked to get this trial open to patients. We also have had a lot of amazing funding for this trial. OneCure is a comparative oncology specific foundation at CSU that provided a lot of funding. Swim Across America has given funding, and then an investigator-initiated trials committee here on our campus did, as well as funding that I've been lucky to have to continue my work on the trial. So that is it for the presentation, and I'm happy to take any questions. I wonder if I should stop sharing.
Sure,
Did
yeah.
you
If you want to
leave the
start
trial
sharing.
or leave the slides up? What do you think?
You know what? Well, actually, maybe let's leave them up in case
Okay.
sometimes people have questions that refer back to slides. So that would be great. And we already have some questions, a bunch of questions come in. So we'll just
Okay.
go right into those. Okay, so first question was, is medication compliance with these meds an issue at all within pediatric population since these are PO meds, pills?
We have not had any issue. As is the case with a lot of clinical trials with oral medications, our patients do have to complete a diary um, to tell us when they dosed, and it also helps them to write down any new side effects they're having on those days. We can just kind of keep closer tabs. And then they also have to turn in their bottles at the end of every cycle, and we do a count, really just to make sure everything jives, that doses are going okay. And we have not had any issues. And overall, I think patients have been really happy with how they feel, and hasn't required inpatient time or time in the infusion room, getting IV therapies. And so for those reasons, I think quality of life has been quite good for patients enrolled on the trial. And yeah, compliance has really not been a concern.
Great. Another question came in about dosing. And so this was kind of based on a canine trial. Some dog doses are often palliative rather than cure. Was this considered in developing the pediatric trial?
Oh, sure. So meaning like, how did they land on the doses that they used in the dog trial?
Yeah, and how that informed the pediatric dosing.
Yeah. So as far as I know, I think the initial starting dose they used is like the typical dosing of Losartan that they would use, for blood pressure in dogs. How they landed on the 10 mgs per kg, the increased dosing cohort that they went to, was largely driven, I think, by their preclinical work in the mouse models, and really trying to achieve the Losartan concentrations that they thought would, which of course was all hypothesis. They weren't sure what the concentrations would truly be in the dogs. And so this was, I think, with truly not necessarily palliative intent, although, as we said, even these dogs achieving stable disease of 8 weeks or more was a huge improvement from what would typically be the case for them. These were doses that were intended to hopefully see effect, and thankfully they did. So yeah. And so we have developed our trial, of course, to try to balance typical dosing of Losartan for blood pressure, since that's the safety data we have for it, in kids, but also trying to use the concentration or pharmacokinetic data that we have from the early dose levels to see how close we're getting to the levels that the dogs achieved. And so that's where I said we feel like we've kind of thus far fallen short, which we just had no idea of knowing until we started. And we couldn't really increase the dose before at least identifying that the combination was safe in kids at the typical blood pressure dosing. So at this point now is when we're really able to start pushing that dose to ensure safety, but also we're hoping starting to see increasing levels in the blood, which hopefully will correlate to more monocyte migration and ideally better disease control. But that's the hope.
Great, thank you. Another question coming in about potential biomarkers of response for this combination. And so the question is, would you recommend this combination for someone who had a higher expression of VEGF? Your thoughts on that?
Yeah, really good question. Although our veterinary colleagues have used this monocyte migration assay and the kind of CCL2 levels in the blood to try to correlate with response, they were not able to identify predictive biomarkers, meaning which of the dogs is gonna respond. Like they couldn't look back and say, this dog at baseline had this finding and more of them that had that responded to the treatment. So we do not have that yet. Certainly something that would ideally come from further research if we find that it's safe. For sure, that would be great to know. Who should we give this to? Because probably there is a subpopulation of patients who will respond better, as we think is the case with most treatments. We just don't know how to identify that.
Right. And then another question about just kind of clarifying eligibility for the trial. So a patient who had a relapse, on her second relapse, but had thoracotomies to remove the nodules.
Mhm.
And the Mets were smaller. I guess they were like 2 4 millimeter nodules. But I know you had that expansion cohort for a resected disease. And so
Yeah.
that, can you maybe just clarify again when that will open?
Yes. So currently, we'll go back to like so it it kind of depends on what we find with dose level 3 and if we opt to go to dose level 4, or, it's possible with preliminary data, we may change the plan for dose level 4 also, or skip it entirely. I just don't know yet. But yes, the expansion cohort where you can have totally resected disease or small tumors won't open until after we've identified the best dose. So it's hard for me to give an estimate, but certainly I'd say we're still like months away. As you can see, it's been a slow accruing trial just because we are small in terms of number of sites and it's overall a rare disease with, we have specific criteria and such to enroll. And so it's hard for me to say how long until we're there, but I think at least months away.
Mhm. And just to clarify, so you had mentioned that to date you hadn't seen tumor response at the lower dose levels, but as long as you're just establishing safety profile at those higher dose levels, you
Mhm.
would still continue with the cohort expansion for resected disease, regardless of whether or not you see
Correct.
tumor response at those dose levels.
Yeah, I think the main reason we would stop the study would be if we were concerned about safety, which
Mm.
thankfully so far we have not.
Yeah, no, that's great. Because I was going to say, I
Yeah.
mean, I would imagine, you know, potentially you might see hopefully better response with low tumor burden versus
Yeah.
high tumor burden. So it would
Yeah.
be great to be able to still continue in that cohort expansion with
And
resected.
that's kind of what our veterinary colleagues have hypothesized too, that, certainly could this be more of a preventative strategy too? I mean, they saw responses, they got objective responses with the combination, but using it in the setting where disease has been resected or is very low burden and trying to prevent the development of these new metastatic sites by kind of inhibiting the recruitment of those monocytes, is that the better place for this therapy as opposed to trying it when there's lots of disease around and bulkier tumors? But certainly because the goal first is to just identify the safety and the best dose, we wanted to be able to enroll kind of all patients. And so we don't know yet.
Yeah. Okay. Totally. As we want to circle back to that, but I also want to make sure we answer this question that came in about eligibility and inclusion criteria. So you had mentioned there were, the issues with bleeding, and so complications with surgeries. If a patient needed to stop to get a surgical procedure like a prosthetic washout due to infection, for example.
Great question. This is kind of a common thing with all of the TKI class that we do know it can impair wound healing. And so there is I think our you can't have had a major surgery within 7 days or so to enroll on the trial. And you are able to have surgery if needed. Things come up unexpectedly. So if you're on the trial and needed a surgery, we just have really clear language about how long to hold the sunitinib. You wouldn't want that to have that going during a surgery because of bleeding, but also because of wound healing impact. And so we would want to, for safety reasons, have it held for a certain amount of time. So, but yes, that is all kind of written out in the protocol and allowable.
Mm. And sorry, can you clarify again what the washout would be for radiation therapy? Not cardiac, but just like if it was
Oh,
for
I
local
don't know
control.
if I remember specifically, but I can pull it up right here while we're talking.
Okay. But it's okay to have radiation therapy
Yes, you can
prior
have
to that.
had prior radiation for sure. The only limit is just that specific cardiac irradiation above that
Right.
dose. Yeah.
Got it. Um, and some of that detail may be listed in the clinicaltrials.gov page.
It's never that good about giving washouts, to be honest. I
Okay.
feel like that's one of the it's just such basic information. So I'm happy to find it. It'll be easy.
Okay, that would be great. Because yeah.
Okay. Radiation, if it's local radiation, which most of this I think would probably be like to a small area, it's 14 days or more before you could enroll on the trial. If it's a bigger area like the pelvis, where we would worry that it could really substantially affect the bone marrow. So it kind of, the radiation oncologist would help us decide how substantial a hit to the bone marrow a radiation site is. That prolongs it to 42 days or more. But for most patients getting localized radiation, it would just be 2 weeks.
Okay.
Yeah.
Great. Thank you for looking that up in real time. So I did want to circle back, though, to kind of what we were just talking about with, potentially efficacy with low disease burden versus high disease burden. And also, since this is like repurposing a drug that's kind of commonly used for high blood pressure, what about just Losartan in combo with MAP, with like what the current standard of care is? If there are minimal toxicities, and we know that, similar to the pancreatic cancer trial, right, where they used it for the neoadjuvant therapy. I know it's often easier to do a trial in relapse disease and changing the standard of care, but thoughts on that?
Yeah, I think that would be the goal. You're right. Usually we start with evaluation of a novel drug or age, combo in the relapse setting, but that's not, we recognize that that's not always the smartest, right? Because again, that might not be the population that benefits from it, and we may be missing things that we should just be trying up front. But it is just harder from a safety standpoint to not have identified the safety and dosing first before we added it to something like MAP. I will say, after the publication from that like pancreatic cancer trial, which obviously was all adults and not pediatric at all, but in our patients who need a blood pressure medicine for other reasons, like they just have high blood pressure, I know our group here very commonly uses Losartan above other agents. I don't know if it's the typical blood pressure dosing that we'd be using. And so we just don't know if that is high enough concentrations that it's getting to where the dogs were. And so I think that's where a trial like this needed to be done, to really try to push that Losartan dose and understand that it's safe first with the Sutent combination. But I absolutely think that that would be the ultimate goal. Actually, I didn't mention this, but what the dogs are doing now, what the Cancer Center at CSU is doing now, is a triplicate trial. So they're doing Losartan, Sunitinib, and a drug called Latorixin, which is also an immune modulator. And so we don't have results from that yet, but they're already like, well, when could we potentially add this third drug? And I think that one would obviously is not FDA approved. And so would definitely require more pediatric safety information and reestablishment of dosing once we know what these two drugs safety and dosing should be, then adding that. And sometimes it feels like such a long stepwise approach to be doing this, but ideally for the safety of patients, but.
Sure. Another question is, and I knew I was kind of curious, Sunitinib, there's a canine version of that drug, but there are some other TKIs that have been currently more commonly used for osteo, cabozantinib being one, or regorafenib. And so curious if, and those are both, pan TKIs as well. So I'm curious about using Losartan with different TKIs, if that was tested, or maybe we can't easily test it in canines because there isn't a canine equivalent.
That was exactly the issue. We tried to make our trial as parallel as possible to the canine. And, we don't know yet which of these TKIs is better. We definitely use some of the newer TKIs commonly with our patients as well. And so we did definitely talk through that. Like, are people going to be interested in taking Sunitinib, which is an older TKI, with this combination? But it just felt like what made the most rational sense because it mirrored exactly what the dogs were given. But that would be another question. If this trial is safe, but not showing efficacy, do we try to switch it up completely and put Losartan with chemo, as you say? Or do we switch up the TKI? Like, are there other approaches we should be taking? So very good question.
And then I'm going to sneak in one last question before we wrap up, which is, so it sounds like so far it's been very tolerable, like not that many horrible adverse effects. But I'm curious, like, do canines, are there adverse effects very similar to what you would see in humans? Like, I know, for example, on the TKIs, often you get like the dry hands and feet, and I'm just curious how well it mirrors what we would see.
Yeah, I definitely learned a lot about chemo administration and clinical trial conduct in dogs in working on the development of this trial, because I equally was unsure. I mean, they wonder how we figure out from a 2-year-old what their side effects are, but I wonder how they do from a dog. So, they share a lot of the same side effects. I think the bigger concern, because they were using the typical dosing on the Tosarenib, was pushing the Losartan dose. So I think mostly the concern was Losartan side effects, like the blood pressure dropping and more objective things that they could follow just with vital signs, which they didn't see in the dogs. And in general, like the dogs still had an appetite. They were maintaining their weight. They had energy, like all of those kind of more subjective things were able to be followed in that way. So yeah, great question. It's definitely a different world on the canine side, but
Yeah, well, thank you so much. This was so great. Thank you for joining us on Osteobites today for making better for pediatric cancer patients. More information on this and all Osteobites can be found on our website at mibagents.org, on the MIB Agents YouTube channel, and at your favorite podcast place. Next week, we're going to be dropping a new episode of Osteo, our AYA cancer podcast. Osteo warriors Mia and Sammy will be discussing toxic positivity in an episode titled When Positivity Silences Pain. And we'll be back with Osteobites on July 24th. We're going to be joined by Dr. Karen Pollock and Dr. Pandya from Indiana University. And they're going to be discussing their work studying the simultaneous targeting of CDK4/6 and BETs, and how that may be independent of RB status in osteosarcoma. You can find our Osteobites lineup for the next few months on our website. And if you ever have any ideas for topics you'd like to hear about, please feel free to email us at events@mibagents.org. Thank you again so much, Dr. Faulk, for spending time with us today. And thanks to all of you for taking time out of your busy day to join us. We hope to see you back here in a couple of weeks on July 24th when we talk to Dr. Pollock and Dr. Pandya. Thanks, everyone. Thanks so much, Dr. Pollock.
Thank you. Nice to see you all.